Great. So it's recording now. Great. So today's teaching session is cardiology in OSCE approach. So what we'll be going through today is a cardio history. I'll do that briefly because I'm sure you've been over that quite a few times, but important things to ask about, and then we'll do the examination and some specific signs and what they mean, because I always found that quite hard to remember. Then we'll do some cases, particularly focusing on murmurs, heart failure, and heart attacks, so MIs, okay? Firstly, in a history. So a classic cardio history is you're probably in an OSCE, you get chest pain or breathlessness, like really classic stuff, maybe syncope. So these are the things I'm sure you'll know to ask about. The common presentations, and then with each presentation you want to really explore it. So you want to do Socrates. You've probably heard of Socrates, but if not, it's up on the screen in a minute. And whatever symptom they're talking about, you ask about the site. If it's pain, you ask about the site, the onset, the character of the pain. So if it's, say, if it was central chest pain, so what kind of chest pain is it? They say crushing. Whether it radiates anywhere, so it might radiate to the jaw in an MI situation. Associated symptoms, might have felt sick, might have had some sweating. The timing, how long did it last for? E for exacerbating or alleviating factors. So like, I don't know, taking the GTN spray made it better. And then severity, you can ask them on a scale of 1 to 10, with 10 being the worst pain you've ever felt. How bad was this pain? So that's a good way to explore symptoms. If they give you like multiple symptoms, just try and explode each of them. It's like quite a good way to get organized in your head. But okay, you said that you felt sick and you had chest pain. I'll talk about the chest pain first, and then ask about all those questions, and then do the same for the sickness. Like, how long did it last? How many times? Blah, blah. And then for a cardio history, that past medical history is quite important. So I like to ask quite a general question. I just say, do you visit your GP regularly for anything? They probably do if they're older. And have you had any previous similar admissions? People often, if they've had angina, will come in several times just to check it's not a heart attack, so it's sort of like on the cusp. And have they had any surgeries, so chest operations are important to note. If they've got a pacemaker, that's quite important to know as well. So if you say, do you have any other medical problems, and they say nothing, you can then suggest, do you have high blood pressure? Do you have diabetes? Just because those are risk factors, and then in an OSCE station, they would know that you're on the right track, and like you're looking for certain things that might predispose you to having cardiac problems. And then if they've said they have high blood pressure and diabetes, you're expecting in the drug history that they will be on some medications for those. So ask what medicines they take. And then just don't forget to ask about allergies. It's quite a good thing to note with OSCEs. Social history is also really important. So they're smoking, they're drinking, those things can make you more likely to have, say, a heart attack. And then their family history, other family members dying at a young age from heart attacks can mean that they have familial hypercholesterolemia. Or just like a predisposition. It might just be, family history is definitely important. It's sometimes hard to tell if it's how the family, like what their diet is and like how they've been brought up. So it might just be that they're all quite unhealthy. So that means they're more likely to have atherosclerosis. But whether it's due to genetics or due to their lifestyle, it's still important to ask about what their close family members are like. And then a review of systems. I found OSCE Stop really useful for this. And before my OSCE, I did just draw out a stick man on an A3 piece of paper and write all of the symptoms for any system that you might get. And then when you're talking through it, I would go head to toe and ask them. So at the end of a history, I would usually do it then. People do it either at the end of history of presenting complaint, so they cover all the symptoms. I like to do it at the end of my history just to do a head to toe in case I haven't mentioned anything. So I say, if you had any fits or faints or funny terms, have you had any headaches, any changes to your vision, any changes to your hearing, changes to your sense of smell, changes to your taste. That's quite like detailed, you don't have to ask all of them. And then any chest pain, any breathlessness, any abdomen pain, stomach pain, how's your waterworks, how's your bowels, and then don't forget joints, so having any joint pain or swellings, and then their skin, any changes to your skin recently for like a rash. Okay, and then don't forget ice. Liverpool like ice a lot, so their ideas, their concerns and their expectations. I'm sure your communication sessions, you've been over that, but just not to forget it. And that's Socrates. If you haven't heard it before, I find it quite useful. Feel free to take pictures of the screen, I don't mind. Or these slides will be up on YouTube. Okay, so moving on to an examination. On the lead up to OSCEs, I just practiced all the exams. So just get you and a few friends and just do it on each other and then give each other feedback and just keep doing them. It's really repetitive, but it does drill it into your brain. Geeky Medics, the best like mark schemes, I think. So if you just go on their website and then any examination, this is the cardio exam mark scheme, and just mark yourself against that. So like, don't look at it, do the exam, and then have someone else to give you feedback. So cardiac specific signs. Throughout an examination, I want to ask you guys if you know what a collapsing pulse might indicate. You can write it in the chat. Any ideas? Do you know how to do a collapsing pulse, how to test for it? Yeah, well done. It is aortic regurg. It can be some other things, and I'll put them up on the screen in a minute, but that's usually the thing that you're trying to elicit. And the way you do it, if you haven't heard of it before, is you feel their pulse and say, you ask them, do you have any problems with your shoulder? Because I'm going to lift up your arm quite quickly. And then you feel like this, just put your fingers all down their arm and then lift it up quickly. And then if they do have a collapsing pulse, you can feel the pulse sort of here instead. So it's like strong here at the start, and then it just, it's also called a water hammer pulse because it just like sort of drops like this, and then you find it kind of here-ish. So that's if you haven't heard of it before. What other signs? So a radio-radial delay, do you know what that can indicate? While you're thinking about it, it's when you feel both of their pulses at the same time, both radial pulses, and then if they're out of time, that's the radio-radial delay. Yeah, coarctation, well done. Great. So a collapsing pulse is usually aortic regurg. These are other things to bear in mind. I mean, I don't think I really knew that much that they can be shown by a collapsing pulse, but just things to remember. And then radio-radial delay, aortic coarctation or dissection. So if they're, say if their like blood pressure was quite low and you're quite worried about like abdominal pain or something, radio-radial delay, and they haven't had it before, then it's quite worrying. Okay. And heaves and thrills. So in an examination, you feel across and then here and then underneath down here for heaves and thrills. So a heave is when you can feel like the chest banging against your hand, and it's like just an exaggerated like a pulse like down here. So that can mean hypertrophy. And then a thrill is a palpable murmur. So that's less of a banging sensation against your hand, more of a vibration. So it's usually here that you can feel them, or like in any of the areas where the valves are, but it's a palpable murmur. So in the examination, you'd say I'm feeling for heaves and thrills, and then do that, and then you take that off. Great. So those are things that I think are quite specific to a cardio exam. Then there's some hand signs. So starting from the left, this one, can you type in the chat what it is? Yeah, splinter hemorrhage, well done. Okay, does anyone know what the middle one is? So this and this one, they're quite similar, and it can be confusing. If you get them mixed up, it doesn't matter. But there's two things. Yeah, Osler node, well done. So this is an Osler node. Osler nodes are usually at the tips, and Janeway lesions are more likely to be here. Oh, I just gave it away. But the third one's a Janeway lesion. So all of these reddish dots. And these three hand signs, they can indicate one disease. Do you know what it is? Yeah, endocarditis, infective endocarditis. So the idea being that these are like little microemboli that get spat off. So it's like, it's not very good. And it's just little blood clots here and Janeway lesions on your palm. Out of Janeway lesions and the Osler nodes, do you know which ones are painful? Because that's a good differentiator. Yeah, well done. Osler nodes are painful. And the way I tend to remember it is Osler ouch and Jane no pain. I've got quite a few mnemonics that you don't have to remember them, you don't have to use them, but I find them really helpful. So these are painful, and it's kind of misleading. You'd think that Jane would be pain, but no, it's Janeway lesions, no pain. Okay. And they are all signs of infective endocarditis. Well done. This one, it's a classic. Do you know what it is? In every system examination, it comes up. Can you test for it by going like this? Yep, well done, it's clubbing. Okay, so it's good to know a few things that cause clubbing for each system. I'm just going to talk about the cardio ones. Do you know any cardio diseases that can cause clubbing? Don't worry if not. It's almost a trick question because there's not that many for cardio, whereas for resp and GI there's a lot more. So I'm just going to tell you. So yeah, it's clubbing, and usually with any system, it's chronic conditions that can cause you clubbing, and more specifically, chronic conditions that mean you're slightly hypoxic, so you run on like slightly lower oxygen. So for cardio, congenital cyanotic heart disease is a big one, and also an atrial myxoma, which is a non-malignant tumor of the atria. It's very specific, very niche, but if you say it in an exam, like they ask you what are the cardiac causes of clubbing, just atrial myxoma, and that would be fine. Infective endocarditis can cause it, but it's mild, so I didn't tend to, that one didn't come straight to my mind. So here's a nice little mnemonic if you want to think about the cause of clubbing in other systems as well. This is from MedMnemonic, it's on Instagram, it's quite a good page. And yeah, so like for RESP, it's cystic fibrosis, lung cancer, lung abscesses, etc. Okay, so start with this left one in a cardio sense, because it's quite a like normal looking face, and yeah, it could also be other things, but for a cardio examination, what would you call this? It is flushing, yeah. It's a malar flush. Well done. So it's a malar flush. Do you know what it can be a sign of? It's quite subtle, just like redness of the cheeks. Okay, it's also called mitral facies. So yeah, it is another murmur, but it's mitral facies. It is, oh, I've just given that one away. But there you go, mitral stenosis. It's quite specific, but good one to know. So these, I have given it away with xanthelasma. That's what this is. Do you know what it actually is? What's causing it? Yes, cholesterol deposits. Well done. And these are other pictures of cholesterol deposits elsewhere in the body. Do you know what it's called if it's on your hands? Don't worry about the spelling. I know it's a bit of a weird one to spell. On your hands, it's, yeah, xanthomata. Well done. And in your eye, that's a corneal arcus. Yeah, well done. So they all indicate hypercholesterolemia. Another weird way of remembering, I'm sure that you probably know the difference anyway, but there's xanthelasma and xanthomata. I know that this one's xanthomata because it happens on tendons with a T in it. So xanthomata on tendons, xanthelasma in your eyes. But yeah, hypercholesterolemia. And what drug can you give people if they have high risk factors and you want to lower their cholesterol? What drug is that? Yeah, well done. Statins. Great. Okay. And finally, examination findings of the chest. What's this on the left? I mentioned it earlier. You can see a little bump under the skin. What do you reckon that bump is? Okay, it's a pacemaker scar. So this is usually where people would have pacemakers. It's just by their left clavicle. It's usually on the left-hand side. Okay, so that's something to look out for. So when you get to the part of the examination where you're inspecting the chest, just say, I'm looking for any pacemaker scars. And then in terms of this picture, a good, quite like concise way of saying it is, I'm looking for if they have sternotomy or thoracotomy scars. Those are common scars if they've had cardiac surgery. So it just sounds quite nice and rolls off the tongue. Okay, and then finally for auscultation, these are the areas that you would auscultate in. You would go aortic, then pulmonary, then tricuspid, then mitral. I personally remembered this using All Prostitutes Take Money. However you wish to remember it is up to you. You start from the right and you just go across and then here and then under your arm here. I quite like this picture just because it shows that where you're listening is not actually where the valve is. It's just where the noise radiates to and where it's heard best. So for the aortic, second intercostal space, right sternal edge, that's where it's heard best. But we all know the aorta is it's in a different position. So it's sort of like the sound is echoing, the sound of the valve snapping shut is echoing through the chamber, and like your mitral valve, you hear it best at the apex of the heart because it's just like the vibration. Okay, great. So if it will be helpful to you, I can go through a cardio exam. Say in the chat if that would be useful, because I don't have to, I can move on, I've got some cases, or I can just do it start to finish, just to like, so you know the order and the flow of it. You can do thumbs up or thumbs down. Okay. Okay, I'll go through it quickly. And because we've spoken about the specific signs, like for example, with the hands, if I'm actually doing it and they want to present as I'm going on, I'd say I'm looking for any splenic hemorrhages, I'm looking for clubbing, but I'll just go through it quickly. Okay. So first of all, you'd start by, I'm going to get out of this so that you can see me a bit better. Okay, so I'd say, hi, I'm Monica and I'm one of the 5th year medical students. Can I confirm your full name and date of birth? If they're an inpatient, check that on their wristband. I'm going to be doing an examination of your heart today. Have you ever had this done before? And they say no. So it will just involve me having a look, a feel, and a listen of your chest. I'll also be looking at your hands and your face. Is that okay? They say yes. And I'm going to need you to be undressed from the waist up for this examination. If it's a woman, you can say you can keep your bra on. And for this purpose, I've got a chaperone present with me. Am I all right to continue? Okay. So to start off with, you always step back at the start of examination. You always step back and do general inspection from the end of the bed. So you look around, there's no GTN spray, there's no oxygen, just mention a few things relevant to the system. The patient looks comfortable and well at rest. And they're talking to me and they're awake and alert. So I'm going to start by looking at your hands. So you go towards them, you look at their hands, you check their cap refill time. So you hold it down for 5 seconds, and then if it's less than 2 seconds, that's normal. So check their cap refill, check the temperature of their hands. Okay, and then you check for nail signs, as I said. And then I'm going to feel your pulse. So you can feel it and count it. So I would say to the examiner, I would check this for 30 seconds. If it was regular. If it was irregular, I would check it for a full 60 seconds and then say what the rate would be. And I'm also going to feel both of your pulses at the same time, so checking for radial delay. And now I'm going to do a collapsing pulse. So as I showed you before, you lift up the arm and see if the pulse moves down. Okay, I'm now going to feel your brachial pulse. So you feel in here. So that will tell me the volume and character of their pulse. And I'm going to take your blood pressure as well. So I would take their blood pressure, but for the purposes of this exam, I'll just carry on. And then I move up to their face and I ask them, can you pull down your lower lids like this and look up? So I'm checking for conjunctival pallor and any corneal arcus around the iris. And then could you open your mouth for me? So checking for central cyanosis, looking at their dentition, because that's important for infective endocarditis if it's poor. And then looking at your face for any mitral facies. And now just relax on the bed. So the patient is at 45 degrees. You ask them to lie back and look to their left. So you're looking for their JVP, and it's abnormal if it's more than 4 centimeters above the sternal angle. And then you're going to feel for their carotid pulse, and you wouldn't feel both sides at the same time. And now that I've done all of that, I'm now going to inspect the chest. So I'm looking for any sternotomy or thoracotomy scars, any pacemaker scar, and I'm also going to inspect the back of the patient. So you look at the back as well. And then there's the palpation. So you would feel for heaves and thrills in the places I said, and you would feel for the apex beat, which is 5th or 6th intercostal space, mid-axillary line. So I've now done the palpation, and now I'm going to auscultate. There's no percussion in a cardio exam. So auscultation, you listen in 4 areas with your bell, and then you listen in the 4 areas with the diaphragm. And then you perform accentuation maneuvers. So when I'm listening in the aortic area, they can lean forwards, and that might accentuate aortic murmurs. There's a place called Erb's Point where it's on the left sternal edge. So aortic is normally 2nd intercostal space, right sternal edge. Erb's Point is 3rd or 4th intercostal space, left sternal edge. And if they're leaning forward, that will accentuate any aortic murmurs. I've got that written down later on, don't worry. And then leaning to the left will accentuate any mitral murmurs. Okay, and for left-sided murmurs, if they breathe out and hold their breath, that will accentuate aortic and tricuspid murmurs. And right-sided murmurs, mitral and pulmonary, those will be accentuated if they breathe in and hold their breath. Okay. And now I need to listen to the bases of your lungs for any pulmonary edema, any like fine crackles, and then I'm going to feel for sacral edema and feel for peripheral edema. Okay, you could also listen to the carotids for any bruise. So that's a quick rundown of the exam. And then they might ask you some questions after. Okay, so I'm going to reshare my screen and carry on. Okay. So there's the mark scheme again, if you want to refer back to it. Yeah, at the end, you thank the patient, wash your hands, and like things like introduction and the wrapping it up and just being really polite to them, these can get you marks. So that's all good to use. Okay, now we're on to case 1. So it's a 75-year-old female with shortness of breath on exertion. And she's presented with a syncopal episode. Are there any differentials that you might be thinking at this point? Yeah, well done. Aortic stenosis, it's a big one. Anything else you might want to think about? Some differentials. It's okay if not. That's fine. So you do the examination and you're quite right. You hear a murmur. So it's an ejection systolic murmur auscultated over the right sternal edge. So in the aortic position. It's louder on expiration and it radiates to the carotid. So yeah, aortic stenosis, well done. This is what I was saying while I was doing the examination. So left-sided murmurs are accentuated on expiration and right-sided murmurs are accentuated on inspiration. And then leaning left for mitral, leaning forwards for aortic, and there's Erb's point. Okay, and that's specifically to listen for aortic regurg, Erb's point. So when you're learning about murmurs, in all of like my ward time and everything, these are the only two that ever really come up and I'm ever really able to hear. Systolic murmurs are louder than diastolic. So if they're going to give you on an examination, it's going to be systolic. And these are the two main ones. So I'd really just focus on all the details of these two. And you can work out whether like the other murmurs are systolic or diastolic. Because aortic stenosis is systolic, aortic regurg is diastolic, and etc. Like they're always opposites. Okay. So aortic stenosis is described as crescendo decrescendo. It radiates to the carotids and you get a slow rising pulse and narrow pulse pressure. So that makes sense because the aorta is where the blood comes from to go to the rest of your body. So if it's narrowed, you're going to have a pulse that reaches its maximum, reaches its full pressure of systole a lot slower. And it won't reach as high a systole as if you just had a normal aortic valve, so a narrower pulse pressure. The difference between your systolic pressure and your diastolic pressure is not that big a difference, okay? So that's why those two are significant for aortic stenosis. Common causes of this are calcification with age and a congenital bicuspid aortic valve, just in case they ask you. Calcification with age is quite common. Also called aortic sclerosis, if you hear that. It's the same thing as stenosis. It's literally just hardening of the aortic valve. So mitral regurg is a pansystolic murmur, described as blowing, and it radiates to the axilla. Common causes of mitral regurg are mitral valve prolapse, post-MI papillary muscle rupture, and people with Marfan's disease can get it at a younger age. So this is just a little thing, you might have heard it in lectures before, but it's just the reason that a mitral valve is called mitral. It's because of like a bishop's mitre, and it's just got two parts to it. It's these hats that they're wearing, and it's just got two leaves, and that's why they called it mitral, because it's bicuspid. So I just found that quite interesting. This is good to refer back to. This is the crescendo, decrescendo I was talking about. It goes up and then down, and that's just like the sound of it. Whereas these are more this is pandiastolic, this is pansystolic, and it's just that constant throughout systole. Okay, you can look back at that if you need. So, second case, we've got an 80-year-old male with shortness of breath and leg swelling. What are some differentials? Yeah, nice. Heart failure. So that's a pretty bog standard, like you're quite sure as to what the diagnosis is, it's quite specific. On examination, they have pitting edema in their legs and a displaced apex beat, and you hear a third heart sound. So all these things confirming that you think it's heart failure. So common symptoms with heart failure, things you'd want to ask more about. So they say they're breathless. Is it at rest or is it when they exert themselves? And how much are they exerting themselves to get breathless? Orthopnea, so a question I would ask is, how many pillows do you sleep on at night? Orthopnea is lying flat and you get breathless. So if they have to sleep on several pillows or they have to sleep in a chair, you know that it's quite bad. PND, paroxysmal nocturnal dyspnea, is when you wake up in the middle of the night gasping for breath. So that's another question I would ask them about. A cough with pink frothy sputum, that's quite textbook. I don't think people really actually have it, but it's very textbook for pulmonary edema. So you can ask about a cough and if they bring anything up and what colour it is. And swollen ankles are things that patients complain of a lot, especially when they know that they have heart failure and it's worsening and they need to just stabilise on like furosemide or something. So on an examination, you would find signs of respiratory distress, or you might find these signs. So you can find that they're pale, tachypneic, tachycardic. They might have a raised JVP, so that's more than 4 centimeters from the sternal angle. And a displaced apex beat, meaning that there's hypertrophy. They have an enlarged heart. So reduced breath sounds at the lung bases and fine bibasal crackles, these are things that indicate pulmonary edema. And this is also edema, so just fluid overload kind of thing. Their heart just can't function as well. It's having to work harder. So these are good questions to ask in history. How many pillows do you sleep on at night? Do you ever wake up at night gasping for breath? So that's PND. People, I think I've been taught before that like patients complain that they'll like have to run to the window, like they have to sleep with the windows open, like they like run out and like get fresh air. So they really wake up super breathless and just need some more air. And how far can you walk before getting breathless? So there is a severity scale that you can use to determine how bad someone's heart failure is. Does anyone know the name of it? I'd be quite impressed if you did. Good try with MRC. Yeah, it's MYHA. Well done. So that's the New York Heart Association. And that tells you the severity of someone's heart failure. MRC, I think, is more COPD. So the stages of heart failure, class 1 is like there's no real limitation. So you're trying to determine how long it takes to get them breathless. So class 1 is like, yeah, they can do normal ordinary exercise. Class 2, they get mild symptoms when it's like strenuous or like sort of mild exercise. Class 3, they yeah, it's walking a short distance. So I'd go by 100 meters. Sorry. Okay, and then class 4 is like they're bedbound. They can't really go anywhere because they get breathless so much. This is a mnemonic I find really helpful. So class 1, they can do hard exercise before they get breathless. Class 2, they can go up a hill and then they get breathless. Class 3, they can walk 100 meters and then they get breathless. And class 4, they can't leave home without getting breathless. And quantifying that is good to work out their functional status. And like if you're sending someone home from a ward, you want to know if they're going to need help with things like shopping and like if they need carers at home, if they really can't even like get to the toilet without getting breathless, like they need people there. But also to classify their severity and know how to treat them. Okay, so the investigations and management of heart failure. What are some important investigations that will rule heart failure in or out? Yeah, BNP, exactly, and echo. Those are the two most important. So whenever asked about investigations in an OSCE, I really like, even I want to like jump in, be like, yeah, do an echo. But I need, in my brain, I need to go systematically, otherwise I know I'll forget stuff. So I always start with, say it was a history station, I say I would like to examine the patient, and then I'd like to do a set of obs, so bedside stuff. Okay, and then I can do an ECG, sort of like also bedside, and then the bloods. So within the bloods is BNP, and then you can do all the other bloods and justify them however you need. So full blood count to check if the patient's anemic or if they have any infections. UNEs to just establish a baseline, LFTs for a baseline, CRP, to see if there's any inflammation, and I want troponins to see if they're having any cardiac ischemia. Okay, and echo, that is diagnostic. So you really have to do an echo before you can be like, this person has heart failure. Also on a chest x-ray, you can get signs, so cardiomegaly, and you can see pulmonary edema on a chest x-ray. It's helpful, but it's not like one of the first things you do. Okay, and to help me do it in order, I was taught boxes. So for whenever I need to do investigations, I think bedside and bloods. Bedside and bloods. And then do they need anything from any orifice? So any like swabs of their mouth, any like urine samples. That's like another thing you can take. And then I think x-rays or any other imaging. So it might be chest x-ray, might be like CT. And then I do ECGs, and then any other special tests that are specific. So like if they've had a seizure, might be on an EEG. That just helped me to not forget anything. So I hope that was helpful. So management of heart failure, it's like, part of it's quite conservative because you just need to balance their fluids. So if they're quite stable, you need to just keep an eye on urine output and fluid intake. So make charts and, you know, make sure they're not overloaded, because that is just quite common. And another way of doing this is daily weights, because so much of the weight that people carry is due to fluid. So if their daily weight is fluctuating a lot, you think that is mainly fluid driven. And then you can give them diuretics if they are overloaded, such as furosemide. If it's a slightly different presentation and a patient with heart failure has come with acute pulmonary edema, you're going to want to do these things instead. So get them on high flow oxygen because they need the oxygen. IV morphine and nitrates, and high dose diuretics, so IV furosemide is often used if they're in acute pulmonary edema. Okay, so this is the final case. We've got a 62-year-old female with central crushing chest pain. It radiates to her jaw, and she's had shortness of breath and sweating. So what is the, well, I say differentials, what is like our diagnosis here? Yeah, great. So you're thinking it's an MI. For me, this in past OSCEs, this has been a history station. So you would Socrates the pain, you would do ICE, be like, what are you worried about? What do you think it is? But yeah, you want to get management going pretty quickly because it's an acute situation. So this is the history. Yeah, you ask about social history and ask about family history. So she has a 40-pack year history of smoking, she has hypertension, diabetes, all of the risk factors for an MI. So you're thinking query MI, and what investigations would you like to do? What are like the main things that would tell you it's an MI? Yep, great, ECG. And then, yeah, the blood test, so troponins. Those are like the big things you want to remember. But once again, go through it systematically. So I'd want to, in this situation, because it's quite acute, say I'd want to inform a senior early on. I want to get some help. I would complete the history. I'd do an examination of the patient. Come up with some differentials. So make sure you're ruling them in and out in the history, such as, is this pain associated with food? Do you find it comfortable to lie down? So I'm thinking like gorge, because that's quite a common differential for an MI. And other chest pain. So if the patient's actually like quite young, you want to determine like if they've had any like recent stress, because chest pain can be anxiety driven. Not that you're ruling out MI in a young person, because it does happen, but you just want to keep your mind open, as well as doing the relevant investigations, because anyone with chest pain gets an ECG. Like, that's just standard. So you would do a set of obs, you would get an ECG, you would do their bloods. So serial troponins, you want a full blood count, UNEs, a glucose, and an ABG or a VBG. That's absolutely fine as well. And you want to refer them for a coronary angiogram. So you're thinking about like the definitive management later on. So like just think about that stuff early, because it's quite time critical. Okay, so this is an example of a STEMI, great big ST elevations. Does anyone know whereabouts in the heart this STEMI is happening, with V2, 3, 4, and 5 having the main elevation? Yep. So this is an anteroseptal sort of picture, like an anterior MI, septal MI, which is supplied by the left anterior descending. Well done. This is a good picture to go over. I look at it usually quite close to the exams, just to know your areas and where ischemia, like what means what. So lateral leads, inferior, and if it's inferior, that's usually the right coronary artery. Okay, and then these are LAD. And lateral, left circumflex. That's the most common. So there are some variants there, but left circumflex is most common for lateral. Okay, so the management of an MI, can you type it into the chat? We're on the home straight now, almost done. Brilliant. Yeah, and out of MONA, so we all know morphines, oxygen, nitrates, aspirin, clopidogrel. So what's the most important thing that people get in the ambulance on their way if they think they've had an MI? It's like the one thing that's actually going to help treat it. Yeah, brilliant, aspirin. So it's 300 milligrams of aspirin, and it's chewy aspirin, and they get it in the ambulance when they do like a remote ECG. So like those things happen, bam, bam, like immediately. The other things, yeah, MONA, as you said, or MONAC, I think I quite like that with the C at the end. You want to think of morphine, something I didn't normally consider as antiemetics, because they're often feeling quite sick as well. Oxygen only if their sats are low. Then you want to give them nitrate, so GTN spray, aspirin, and clopidogrel. Well done. The definitive management, so for a STEMI, it's PCI. They want to get PCI within 12 hours of onset of symptoms. So that's why it's quite time critical. If there's not a STEMI, there's like a different end STEMI pathway. So they're going to go home on sort of this type of thing. So you want to risk manage them and try and prevent it happening again. What's that? Secondary prevention, I think. Okay, so this, I think NICE is a really good resource here. So if they've had like STEMI and you've confirmed it, you want to give 300 milligrams of aspirin and then reperfusion therapy. So if they're presenting within 12 hours of symptoms and PCI can be given within the first 120 minutes, then that's the pathway you go down. But if you can't give PCI within 120 minutes, like if there isn't a cardiac center nearby, you would also give antithrombin, which isn't on this pathway. And I would have a proper read of this. I think NICE guidelines are very helpful. Okay, right. I think that's everything. Does anyone have anything to ask? Or any slides you want me to go back to, just let me know. You're welcome to message me if you have anything that you're not sure about that I've said. These are the resources I would really recommend these for OSCEs. Geeky Medics, OSCE Stock honestly got me through essential examinations that absolutely everyone has. And this is quite good for practicing history taking, OSCE cases and mark schemes. It's like one of the books. So I hope that was useful, guys. If you could please fill out the Survey Monkey, that would be brilliant. And okay, so I've got a question. If in F1, would a team help you in such cases, or are expected to do that by yourself? So that's a really good question. From what I've seen, if you think that there's an MI, you escalate it. So because they're under the consultant's care, you want to involve like the consultant so that they know what's going on. It depends if you're there on a night or something, but usually like you can get regs to help you, other F1s. So you're not expected to do it all by yourself. Like the whole idea is to have other people there to help you. So yeah, it's not just going to be you. And there's always people on the other end of the phone, even if they're not directly there, that you can ask questions to.